Hello, my name is Dr. Carly Welch. I'm a Registrar in Geriatric Medicine in Birmingham. Today I will be presenting important results generated through research by the Geriatric Medicine Research Collaborative in relation to care of people with delirium. In this presentation, I will present an overview of delirium and what is known about frailty and delirium, present some of the results of our multi-centre study run through the Geriatric Medicine Research Collaborative, and discuss the pathophysiology of delirium with frailty. Delirium is an acute severe neuropsychiatric syndrome that occurs secondary to physical illness, drugs, and external factors. It is distressing for patients and associated with increased risk of adverse outcomes in hospitalised patients. Delirium occurs most commonly in people who have the greatest underlying vulnerabilities, or who are the most sick. It is recognised that in someone who is otherwise fit and healthy, it may require a severe illness with admission to the intensive care unit to precipitate delirium, whereas in someone who has dementia, delirium may be precipitated by a seemingly minor insult, such as constipation. We know that we don't all age in the same way as we get older. Frailty is a condition of heightened vulnerability to the effects of illness that is defined separately from chronological age, but that some people may develop as they get older. In clinical practice, frailty can be assessed using the clinical frailty scale. People with more severe frailty commonly have higher levels of dependency and are more fragile to the effects of acute illness. We know that delirium is especially common in people with COVID-19. In older people with underlying vulnerabilities such as dementia or frailty, delirium may be the only presenting symptom of COVID-19. Public Health England has now included delirium as a recognised symptom to prompt screening for COVID-19 in people who are older or who have cognitive impairment. Delirium is considered to arise due to a peripheral inflammatory response, leading to a secondary central inflammatory response, with movement of inflammatory messengers across the blood-brain barrier. In the UK, National Institute for Health and Care Excellence Guidance recommend that all adults aged 65 and older, newly admitted to hospital, should be screened for evidence of delirium on admission. Delirium diagnosis should then be communicated to the patient's general practitioner on discharge. Unfortunately, delirium is frequently unrecognised in up to 2/3 of cases. The Geriatric Medicine Research Collaborative is a national trainee-led network for audit, research and quality improvement. We undertook 3 rounds of data collection for adults aged 65 years and older, newly admitted to acute care hospitals on the 14th of March 2018, 14th of September 2018, and 13th of March 2019. The first and last rounds of data collection used prospective data collection methodology to enable screening of patients by data collectors using the 4AT, a retrospective approach that enabled retrospective identification of unrecognised delirium was utilised in the second round. At all rounds, diagnosis of delirium was made based on the Diagnostic and Statistical Manual of Mental Disorders 5. Traditionally, quality improvement projects have been driven locally, and it's often unclear how best to extrapolate changes to other sites. Driving changes nationally using this traditional model can therefore take considerable time. We utilise an innovative approach to crowdsource our quality improvement interventions across multiple sites. We used a shared drive to share documents, including local guidelines, toolkits, and presentations across sites. Our projects were further disseminated via email and social media. Lastly, we presented the results of earlier rounds of data collection at local, regional, national, and international conferences. Our project included a total of 82 sites across the 3 rounds, including 3,013 patients. The overall prevalence of delirium across the 3 rounds was 16.3%, which equates to 1 in 6 individuals experiencing delirium. The prevalence of delirium was similar across each round, with similar age and gender split across each round. The percentage of patients screened for delirium increased across our 3 rounds of data collection. The odds of being screened for delirium were a third higher at round 3 compared to round 1. The likelihood of screening for delirium was increased at sites where a specialist delirium team was present. The likelihood of delirium screening was also increased with increasing age, dementia, and mild to moderate but not severe frailty. Recognition also increased across the 3 rounds of data collection. Odds of delirium recognition were 2.3 times higher at round 3 compared to round 1. Importantly, our studies showed that screening for delirium was associated with over 4-fold increased likelihood of delirium recognition. This effect was not affected by the grade or profession of screener. Odds of recognition were higher at sites that had a geriatric medicine team embedded into the admissions unit. Interestingly, likelihood of delirium recognition was increased in patients with dementia. The likelihood of documentation of recognised delirium on discharge summaries also increased from round 1 to round 2. Although not statistically significant, these effects appear to have been sustained at round 3. The distribution of frailty within our study was broad, with some people considered very fit and others considered very severely frail. We demonstrated a stepwise increase in risk of delirium with each increment in the clinical frailty scale compared to CFS 1 to 3, with the highest risk of delirium demonstrated in the most severely frail patients. These results are independent, adjusting for age, gender, dementia status, and specialty. Unfortunately, the likelihood of delirium recognition was reduced in patients living with frailty. This effect was independent, adjusting for age, gender, dementia status, specialty, and delirium subtype. The presence of delirium was independently associated with increased risk of dying and increased length of stay. Patients with very severe frailty were also significantly more likely to die during admission. These results are consistent with other studies that have shown increased risk of delirium in patients with frailty, although previous studies have mainly considered frailty as a dichotomous concept. So why do we think people living with frailty may be more likely to develop delirium? We know that frailty is associated with a weaker immune system, a term we call immune senescence, as well as increased baseline inflammation. In addition, many patients have weakened blood-brain barriers and cerebral vulnerability related to central immune senescence. Therefore, patients with frailty may be more vulnerable to developing delirium, with seemingly mild illness, even without significant systemic inflammatory surge. It might be necessary to trigger a delirium in a person without frailty. In conclusion, from our studies, we have shown that screening for delirium improves recognition of delirium. Specialist delirium teams improve screening, and geriatric medicine teams embedded into admissions units improve recognition. Frailty is associated with a stepwise increased risk of delirium, and delirium is least likely to be recognised in the most frail patients. Frailty and delirium are independently associated with adverse outcomes. Further research to establish pathophysiology may enable targeted treatment and prevention in frail older adults.